Welcome to today's FERNE learning session on brain biomarkers and the evaluation of ED patients with mild traumatic brain injury. What is the pathology? What is the clinical benefit of this diagnostic test? And what role does this lab have in 2026? My name is Edward Sloan. I'm Professor Emeritus in the Department of Emergency Medicine, U of I in Chicago. I'm also Medical Director of the Physician Assistant Studies Program at Dominican University in River Forest, Illinois. This is the QR code for my information, and I want to thank the people from the Emergencies in Medicine Educational Group who helped provide this original presentation. I have no financial conflicts. I'm FERNE President and Board Chair. You can join us at ferne.org or on social media. And at YouTube, you can join us at FERNE.org, where we have several different playlists, shorts, and longer presentations. This information is available to you using this QR code, and there is extended information including a policy brief, clinical update, and mild traumatic brain injury patient information using this QR code. So, the first objective is to enhance our understanding of mild TBI and biomarkers of the brain and the pathophysiology that creates them. So, mild TBI, brain biomarkers. When considering mild traumatic brain injury, we know that there's at least 3 million ED visits each year from traumatic brain injury, and about 1/3 of them are what we would classify as concussions. Mild traumatic brain injury is the majority of TBI patients, about 85%, and surely most of those have a GCS of 13 to 15, and in fact most have a GCS of 15, which signifies a normal level of consciousness following traumatic brain injury. So, these patients generally have brief or no loss of consciousness, mild headaches, some dizziness, perhaps nausea and vomiting. They generally have a normal neurological exam. About 15% will have some chronic symptoms, but again, these lab tests do not signify or dictate what will be the outcome long-term as a result of the mild TBI. We know that even when there's long-term symptoms, about 85% of those symptoms will resolve within 3 to 6 months after the initial injury. So what are the mild TBI brain biomarkers? There are 3 primary mTBI biomarkers for testing. One is GFAP, one is UCH-L1, and one is S100B. There are some others being investigated, such as NFL and tau, but we're not going to speak of those today. So let's consider the first one, GFAP. It is a structural protein. It marks astrocyte damage, and it can predict the presence of CT lesions. It's a glial protein release, and it detects injury up to 7 days post-trauma. We know that based on the studies, it outperforms S100B, and so is a superior brain biomarker. There are some confounding factors, including age and renal impairment. So we know that GFAP signifies astroglial injury. So we see from this graphic that the source of GFAP is astrocytes within the brain tissue. The second is UCH-L1. UCH-L1 signifies axonal and neuronal damage. We know that it is most useful up to 12 hours following the injury. And we know that the use of UCH-L1 and GFAP when tested together as a multiplex test improves accuracy. So, these 2 tests, when combined, GFAP and UCH-L1, allow information about the presence of lesions on a non-contrast CT to be obtained. So again, this graphic demonstrates that UCH-L1 comes from neuronal injury. So, GFAP and UCH-L1, we know that GFAP peaks a little bit later, up to 20 hours, and we know that UCH-L1 has an earlier peak up to 8 hours with a more rapid drop-off. What about S100B? S100B is another astrocyte protein. It does have a high sensitivity, it's 96% pooled, but a relatively low specificity. This is not very different from the other brain biomarkers that we're talking about. SB100, however, is also released from non-CNS tissues such that extracranial trauma in a multiple trauma patient will elevate S100B levels, making specificity even poorer because of this confounding factor. So, astrocyte injury, we know, elevates both S100B and GFAP. S100B elevation occurs early. We know it's an astrocyte injury marker similar to GFAP. So, in summary, GFAP and S100B from astrocytes, GFAP outperforms S100B, and UCH-L1 comes from neurons. So, what is the mechanism that allows blood-based mTBI detection? It is a series of processes where there's damage to the central nervous system cells, CNS brain proteins are released, the head trauma disrupts the blood-brain barrier such that the CNS proteins are able to leak into the systemic circulation, and then these biomarkers can be tested as a lab test. So, brain injury and biomarkers. So the neuronal injury releases what are intracellular proteins. The blood-brain barrier again is disrupted, and GFAP is an early indicator that appears to correlate injury to neurons and the presence of a structural injury detected on a non-contrast CT. For more information, go to FERNE.org, where you can find content relevant to your clinical practice. We're also available on social media and on YouTube at FERNE.org. You can find playlists and video content that will improve your patient care, patient outcomes, and your clinical practice. So with that, I'd like to thank you. And if you have any questions, you can email me at my email below, and always go to FERNE.org for finding more information regarding how these tests and other strategies for providing optimal patient care will improve patient outcomes and allow for us to optimally utilize our limited healthcare resources. Thank you again for participating in this educational program.